Can you hear me now? Okay, yes. I can hear me now too. So thank you so much for joining us this morning. Obviously, I'm not Dr. Lederer. She's out of town, so she asked me to get things started in her place. I wanted to make a comment that today is our Charlie Smith lecture. Unfortunately, Dr. Smith's health has precluded him from joining us today. But those of you that have been here a while know Dr. Smith as what I would say is being the internist in town. Brilliant man who practiced for a long time, was responsible for teaching many of our students and residents along the way. And one of his grateful patients actually endowed this lecture in his name several years ago. It's been quite a few years, at least 20 years ago. So we're very happy to have this endowed lectureship today. And I will certainly talk to Dr. Smith and give him some updates on how today's talk goes. So I would like to introduce our Grand Round speaker today. It's my pleasure to introduce him. And Dr. Vinay Prasad graduated from Michigan State University with dual degrees in physiology and philosophy. That's an interesting combo. He subsequently completed his medical school training at the University of Chicago, where he was recognized as an outstanding student and received the Chairman's Award in Internal Medicine. He completed his residency in internal medicine at Northwestern University, followed by a fellowship in oncology at the National Institute of Health. He also holds an MPH from Johns Hopkins University and is currently an assistant professor in medicine in the Division of Hematology and Oncology at Oregon Health and Science University. And note that right now Dr. Prasad is on West Coast time, so it is actually 5 a.m. his time, so we're really appreciative that he's here. You might be asking why, as for general medicine, we're having a hematologist and oncologist present, but he has an interest in quality in medicine as well as ethics and has published over 160 papers in some very high impact journals. He's been recognized as an outstanding teacher, both during his training and now while on faculty, and currently serves as associate program director for the Hematology Oncology Fellowship Training Program. He's been invited to lecture both nationally and internationally, and we were fortunate that we could include him here at our university. He's also published a book entitled Ending Medical Reversal, Improving Outcomes and Saving Lives. His work in this area has garnered a lot of media attention, and he's been interviewed by the Washington Post and NPR, among others. He was also covered in a 3-part series of the radio show Freakonomics on NPR. We are delighted that Dr. Prasad could join us today to share his perspective with us, and the title of his lecture is Medical Reversals. Vinay?
Hi, everybody. Thank you so much for having me. And I'm just going to step out a little bit in front of the podium. It's a real pleasure to be here and a real honor to get to speak with you all this morning, especially a lecture that means so much to the community of a really, truly tremendous physician. So it's a great honor, and I thank you so much for your time. And although I am a practicing hematologist oncologist, the majority of my talk will be general medicine and cardiology to my good friend, Dr. Mandrola, who's here joining us. What I'm going to talk to you about today is medical reversal, a subject we've done a lot of research on over the last 8 or 9 years. The talk was provocatively titled, Why 40% of What We Do is Wrong. I hope by the end of the talk that I will convince you that some fraction of what we do in healthcare is incorrect, but I'm not sure you'll be sold if it's 40%. I joked with John that there was a typo in one of the promotional materials that said 96% of what we do is wrong. I think that's a bit high. Even I believe that's a bit high. So I'll try to defend the claim that 40% may be incorrect. In terms of financial disclosure, I receive royalties for having written this book, but I can tell you all, you write a book that's published by an academic university press, and you think about all the hours you spent and all the money you received, you would happily trade that for minimum wage. My work is gratefully funded by a nonprofit foundation that's based in Houston, Texas. And I'm active on Twitter, along with Dr. John and many others in this room, and you can follow me there. But I think the real disclosure of this talk is that some of what I tell you today is controversial. It's not my purpose to disparage particular medical practices, to be critical of specific things, but in the course of giving this talk, I apologize, I will do so. I will disparage many specific things. But the real purpose of my talk is to talk about broad patterns of medical progress, about biomedical innovation, how evidence is generated in this system today, how it's increasingly being hijacked, and some rather famous missteps in biomedicine. So it's really to talk to you about the history and the progress of medical science. What is medical reversal? So if anything, I hope you walk away with is some idea of what I mean by medical reversal. What does that term actually mean? In the picture I've shown here, this is a picture of two Model T cars. On the left is a Model T made by Henry Ford. On the right is the Model T made by Elon Musk. And I think we will all agree that when it comes to automobiles over the last 100 years, we've had steady incremental progress. What we started with was better than perhaps a horse and buggy. What we have today is far better than what we had back then. We've had incremental progress and innovation through the automobile industry. If you think about the telephone in your pocket, we will agree incremental progress. The phone we have today, more powerful than computers we had in the 1980s. The television on your wall, nothing but steady progress. It's cheaper and thinner and bigger and clearer than it ever was before. And I think many of us in this room, healthcare professionals, we take our experience with technology and we generalize it to other parts of our lives, including biomedicine. And we think just as there's been incremental progress with technological innovation, so too has there been incremental progress in the biomedical sciences, that medicine is nothing but stepwise advancement. And I want to suggest that that narrative actually is true to some degree. There are examples that fit that narrative, but it's an incomplete narrative. But here's where it's true. How do we treat peptic ulcer disease? It wasn't that long ago before the treatment of peptic ulcer disease was a large, perhaps barbaric surgery. By the 1980s, we replaced that with a histamine antagonist. We moved forward with proton pump inhibition, which is a better acid suppressive medication. I think about how we treat Hodgkin's lymphoma. If you read case series published from the 1940s, patients with Hodgkin's lymphoma were thought to be condemned, universally fatal, 100% mortality of 3 or 4 years. In the 1950s, Henry Kaplan at Stanford pioneered radiation therapy to cure the first patients with Hodgkin's lymphoma, and he did it fleetingly and at great toxicity. In the 1960s, Vincent DeVita at the National Cancer Institute pioneered MOMP and MOP, combination chemotherapy. And in the late 1960s, Giovanni Belladonna pioneered ABVD, which is the standard of care, arguably until this year, where a drug company wants us to change the B, and it's a heavily disputed trial. But I think when it comes to Hodgkin's lymphoma, steady incremental progress, decade by decade, survival outcomes have improved. What about acute ST elevation myocardial infarction? It wasn't that long in medicine before we didn't even know what was going on with ST elevation MI. We recommended bed rest with an unclear understanding of what the pathophysiology was. By recommending bed rest, we likely worsened mortality, causing PE and DVT. In the 1990s, Topol and colleagues pioneered the use of lytic enzymes like streptokinase, although these were accompanied by some adverse effects and allergic symptoms. They were improved upon, arguably, with tissue plasminogen activator, the recombinant form made by Genentech. And this was improved upon with plain old balloon angioplasty and finally percutaneous coronary angioplasty and the placement of an expanding metal stent. And bare metal was originally used, and now we've moved to drug-eluting stents, such as everolimus. And we can all debate how much of an advance this last step has been. But I think it's clear, when it comes to how we treat ST elevation myocardial infarction, we've made tremendous strides. We have absolute mortality reductions that are among the best in all of biomedicine, and it's a great success story of medicine. So when you think about all these things, you think about your television, you think about your phone, they all are a similar narrative of progress, and that's something to be proud of. But I wish to suggest to you that this is an incomplete narrative, that history so often is written by the victors, and we miss and we minimize the back and forth nature of history, how many things we had been doing that we were extolled by professional guidelines that we ourselves participated in were later found to be no better or worse than a prior or lesser standard of care, including doing nothing. We did it with the best of intentions, but it would actually have been better not to do that. Either we had no benefit or we actually had harms exceeding benefits. And this is a narrative that too often gets lost in biomedicine, but it exists nonetheless. I think of things like the Swan-Ganz catheter as a clear example. It wasn't that long ago when routine placement of the Swan-Ganz catheter to measure right heart and left heart pressures when you wedge it was commonplace in the ICU for patients with shock. Although this catheter provides you with lots of information upon which you can base your pharmacologic therapy, that information is only useful insofar as it leverages improved patient outcomes. And in fact, we know from now multiple randomized controlled trials of the Swan-Ganz catheter that when routinely placed, it does not improve clinical outcomes. Now, many in this room may argue, well, it still has a role. It benefits some people. What about the patients with truly undifferentiated shock? And I don't wish to say it doesn't, and we can talk about that more at the end, but I wish to suggest that the way we had used it was routine. We weren't using it in this sort of very specific way. And as it was used, it did not, in fact, leverage improved outcomes in the clinical trials to date. Routine hormone therapy. The story of hormone therapy in this country is a story, I think, that many of us wish we didn't participate in, wish we weren't involved with. But we were, many of us were. Many people who practice medicine, the best doctors, recommended hormone therapy for women post-menopause. And they did it for a couple reasons. One, biologically, it made a world of sense. Women, while premenopausal, have very low rates of cardiovascular disease, far lower than their male counterparts. Estrogen has 1,000, 10,000, maybe 100,000 biomedical studies showing it has protective effects on the endothelium, on coronary processes, on heart disease. And we paired this biology with a well-done epidemiology study by Mir Stamfer and colleagues called the Nurses' Health Study, where they followed nurses for many years, showed the women who took hormone therapy had better cardiovascular outcomes than the women who didn't. Of course, by 2002, wise people and brave people sought to test this hormone therapy strategy in a prospective randomized trial called the Women's Health Initiative. And that trial reported results in JAMA suggesting that hormone therapy actually increased the rate of DVT and stroke and heart and cardiovascular event. And it has largely fallen out of favor as it was used for routine use postmenopausally. And again, we can debate a little bit later whether it still has some role for women during menopause for symptom control as a short-term strategy. But again, I want to stress that's different than how we had been using it, which was really sort of a blanket recommendation. Finally, stenting. Many medical interventions work, many medical diseases exist along a spectrum. There are illnesses of acute severity where intervention has a clear and incontrovertible benefit, but there are also illness of lesser severity in which intervention is unclear. And the routine use of percutaneous coronary angioplasty for chronic stable angina is one such thing. I think if you look at all the stents placed in this country, we're talking about an industry that has annual sales of about $15 billion. And it is widely disputed what percent of stents are placed for chronic stable angina. It feels like we should know that number, but we don't. But some people place that number as high as 50, 60, 70, even 85%. That's what the authors of the COURAGE trial placed it in their introduction. So many stents are placed for people with chronic stable angina, and you may ask, why is that the case? Well, in survey after survey of patients and what they believe, it actually suggests that patients believe these stents will lower the rate of subsequent MI and improve their survival. Actually, studies as recently in 2015 in JAMA Internal Medicine and BMJ show that patients undergoing the procedure believe that. In an elegant study in the BMJ, they submitted patients with an audio recorder to a physician's office to be counseled about this. They found that 90% of the cardiologists who counseled them did not mention that it did not do those things, did not rid them of their delusion that it would do those things. In 2007, we knew rather clearly, based on the results of the COURAGE trial, to randomize several thousand patients to stents or medical management, that it neither reduced the rate of MIs nor improved survival. So this has been a contradicted claim in terms of those hard outcomes for now over a decade, yet patients believe that who undergo the procedure. In a little bit, we'll talk about the benefit of this on subjective outcomes, which finally had a shakeup last year. So what is medical reversal? It's much more like this car. This is the Volkswagen Diesel. You bought this car because you wanted to put less greenhouse gases in the atmosphere, and in retrospect, you put out 30 times as much. We are loaded with Volkswagen Diesels in our field. Biomedicine is not just the Model T story, it's the Volkswagen Diesel story. And we have Volkswagen Diesels in every part of medicine, in every one of our specialties, as I'll hope to convince you in this talk. So a couple years ago, in a letter in 2011 in JAMA, or back then it was the Archives of Internal Medicine, and in a viewpoint in JAMA, we tried to bring some attention to this idea of medical reversal, these flip-flops in medicine, how we change course. And we define reversal as a large, well-done study, typically a randomized trial, or a trial with better blinding or better controls or more power or better endpoints, aka less bias, when that contradicts current medical practice. And when that study is so good, it really contradicts not just the last study, but the totality of the information prior. We consider that a medical reversal. And I guess I don't want to sound like what we were doing or what we are doing is particularly novel. I think there are a lot of people who are approaching this problem from different angles. We use different language, but we're talking about the same thing. Some people call this no value or low value care. I encourage all of you in this room to follow Dr. John on Medscape, because I think he's written wonderfully about this in his field of cardiology. Some people call this, how do we de-adopt failed practices? How do we deal with contradicted or refuted practices? Some people speak about a movement like with food, slow cooking, slow medicine. How should we adopt new therapies? My friend Adam Elshog and colleagues from Australia made this word frequency cloud of words used in this space. Reversal is on the list, but by no means is it the most common. So I just give you that to show you that other people are thinking about this. And in the talk today, I hope to hit some of these objectives. I'll give you a few selected examples of reversal so you get a flavor of it. I'll take you through some of our papers where we try to calculate how often it occurs. I don't want to just give you anecdotes. I want to give you the data. I want to show you why it's harmful, tell you where it comes from, and tell you what we can do about it. And then if we have time, I will give one of the most persistent and recalcitrant objections to this work that we recently published in the Canadian Medical Journal. And finally, what will evidence-based medicine look like going forward? So here's some examples. I think everyone in this room knows that high blood pressure, being older, and atherosclerotic disease go hand in hand in hand. They affect too many patients, and they often overlap. And we all have patients with very hard to control high blood pressure, and some of those patients may have atherosclerosis, and some of them may have severe atherosclerosis in the afferent renal artery. And if you have atherosclerosis in the afferent renal artery and you have very bad and hard to control high blood pressure, I think it makes intuitive sense that we have a reason why you might have high blood pressure. Because the kidney, after all, makes the hormone renin, and renin is involved in the RAS pathway, and RAS raises blood pressure. So if your kidney is being strangled and not getting enough blood, that may be responsible for your high blood pressure. So it is logical and intuitive that those patients may benefit from a revascularization procedure of the renal artery. And in fact, this was widely performed. It was $1 billion a year in sales from CMS, reimbursement through CMS alone between 2001 and 2010. By 2010 and 2011, we now have 6 randomized trials that test this strategy. In pooled analysis and the analysis of the largest studies, these are all negative trials, and I've shown you these 2 here. This is the Astral study, a randomized controlled trial of medical management versus stenting plus medical management. No difference in renal events or cardiovascular events, which is the primary endpoint of the study. This is the Coral study, the absolute largest trial ever performed to date. Again, absolutely no benefit compared against medical therapy. And the reduction in blood pressure pills that a patient takes was trivial in these studies. It was something like 3.2 in the control arm versus 2.3 in the intervention arm. It barely saved you a pill. And this procedure is not without complications. As many of you know, you can shower atherosclerotic emboli to the toes. You can dissect the renal artery. You can dissect the aorta, very rarely. So here you have a procedure widely performed, billing CMS, billing commercial payers, still in use today. And to date, there is no positive randomized controlled trial of this intervention, period. When I give this talk, particularly when cardiologists or interventionalists are in the room, they point out that these studies excluded some people. They excluded the worst of the worst, the flash flood pulmonary edema, the really catastrophic high blood pressure patients. And I say that's absolutely true. In fact, every reversal study I will show you, there will be some rules about who could have been into the study and who could not be. That's inherently the nature of science. No negative study can prove definitively a practice does not work under some conditions. But the purpose of science, the purpose of biomedicine, I think, is that proponents of therapy have to prove under what circumstances practices work. We cannot have a system where practices are constantly debuted and it's up to critics of the therapies or skeptics of the therapies to prove that they don't work in all the instances. You cannot prove Santa Claus doesn't exist. The person who believes in Santa Claus has to show where he is. has to do with the falsifiability of a hypothesis. So I urge those people who believe it works in critical subsets to demonstrate that in a randomized trial, because in a product that has made roughly $20 billion in its lifespan, there has never been a positive study. And at what point does that burden fall upon proponents of the therapy? Steroid injection for spinal stenosis. I think this is a good one. A few years ago, there was an outbreak of fungal meningitis from compounding pharmacies, and it led to several deaths. And last summer, the CEO of that compounding pharmacy was indicted and now serves time in federal prison for lax oversight of the hygienic practices of that compounding pharmacy. So we, in the wake of such a scandal, cracked down on the filthy compounding pharmacy. But fewer people ask the question, which is, why are so many people getting corticosteroids injected into the epidural space? And the answer is, we're doing that because we think it improves the pain or function of certain conditions like spinal stenosis. But does it do that? So this is a well-done study in the New England Journal of Medicine from 2007 that randomized patients to lidocaine plus a placebo versus lidocaine plus a glucocorticoid, and it measured 3 and 6 week functional outcomes. And as all of you in this room know, the half-life of lidocaine is not long enough to improve outcomes at 3 weeks and 6 weeks. It will wear off. There's no way lidocaine is doing any lifting here. And yet there's absolutely no difference in these outcomes. And the other thing I should say, the glucocorticoid should be doing something here. The glucocorticoid is a long-acting anti-inflammatory medicine, and yet at 3 weeks and 6 weeks, it is doing nothing at all. And both groups improve on many of these scales. And that improvement, it appears to be, is either due to the lidocaine alone, then somehow lasts a little bit longer for unclear reasons, or is due to a placebo effect of the intervention. We'll come back to that. I think this is the trial that got everyone in a buzz last year, the Orbita study. Now, many years ago, in the wake of Courage, proponents of stenting pointed out that although MIs and survival were not improved in that trial, patients felt better. And in the sub-study to Courage that published a year later, it showed that there was a small symptomatic benefit that lasted for a while, but waned off at about 18 months. However, skeptics of that study pointed out, and I was included among them, that the control arm of Courage's medical management, you haven't separated the effect of stenting from the effect of telling someone you stented them. And when you tell someone you stented them, what does that mean? You often can bring the patient back and you can show them their angiogram and you can show tight stenotic lesions like here, here, and here. And you can show you've revascularized them and you can hit the animation button and show the heart beating in real time and show them that this vessel has been revascularized. And that's part of the procedure of stenting a chronic stable angina. And in this trial, the Orbita study, they tried to separate these two things. They actually did a very well-done study. This is a randomized, sham-controlled study of percutaneous coronary angioplasty. And it randomized patients with this disease. So it's, I think for those of us who look at this, this is significant disease. This is not trivial disease. Significant single-vessel disease, often LAD disease, to stenting or a sham procedure where we mimic stenting. And the patients have earphones on. They don't know what you're doing in the cath lab. And you tell them that, we did the procedure or we did a sham procedure. You don't tell them what they received. And the other thing you should know about this study was what was the primary endpoint. So an old study in 1992, ACME, randomized patients to stenting stable angina versus medical management, and it showed that on an exercise protocol, you can improve exercise time by about 90 seconds. And then they've surveyed cardiologists, and they say, what's the minimum amount of exercise time that you consider clinically meaningful? And cardiologists said about 45 seconds. If you can improve 45 seconds, that's clinically meaningful. Then they powered their study to detect a 30-second difference in outcome. Okay, so their study is overpowered to detect the difference that people state is meaningful. It has abundant power. It is powered for 30 seconds. And what they found was there was no improvement between PCI versus placebo on exercise time. It was not statistically significant, but the raw difference was 16 seconds, but the p-value was not significant. So some people say, well, it was an underpowered trial. And I think the author of this study, Daryl Francis, has pointed out that it was underpowered for what? For finding a 5-second difference? You've already declared 45 seconds is clinically significant. 5 seconds would be a triviality. Would you really justify an invasive $10,000 stent for a 5-second difference in a protocol where you're running for about, 7 minutes, 8 minutes in this protocol? And the answer is probably not. So, to some degree, every trial is underpowered to find some sliver of difference, except for our oncology studies. We do a good job of finding them. But And that's how we give our national meetings. So, but in this study, it was very adequately powered to test for reasonable hypothesis. How often does this happen? I think we studied how often it happened in this paper in 2013, and we were lucky we got covered in the New York Times and generated a lot of interest, and eventually we wrote a book about it. So I will say at the outset, there is no ideal way to measure this problem. Every way you could measure it has some pitfall or limitation. This is just one stab at it. And we have another stab that's ongoing that we hope to publish in the next few months. But basically what we did was we took every article that appeared in one journal, the New England Journal of Medicine, as an original article between 2001 and 2010, and there were 2,044 such articles. And these were read in duplicate by 2 reviewers. That is why I say God invented medical students, to do this kind of hard-hitting work. But they also read good articles. These are truly, they're good articles. They've shaped the field. 65% of these articles concerned a medical practice. By that I mean the other third where we found some new gene is responsible, a new genetic mutation also has cystic fibrosis phenotype. Okay, that's the other kind of sciencey article. They publish about a third of the articles in this journal are articles that you might otherwise read in Science or Nature. But 2/3 have to do with what doctors do, what healthcare systems do, what we all do. If you tested something we do, 73% of the time you tested something novel. Is rivaroxaban better than Coumadin? Is ibrutinib better than chlorambucil? Is my new stent better than my old stent? And if you tested something new and if you were published in the New England Journal of Medicine, I can rest assured you had a positive result. 77% found that the practice was beneficial. And when people talk about selection bias or selective reporting bias, this is what they mean. This is impact factor chasing. This is, if you want to publish your article about something new, it better be earth-shattering if you're going to get into the New England Journal of Medicine, because no one is going to cite these articles about the therapies that you wished were successful but didn't. And I think that is a root driver of this problem in these top journals, and I think this has been discussed a lot. But we also found about a quarter of what was published was testing something we had already done, hormone therapy, stenting stable angina, Swan-Ganz catheters. If you tested something we were already doing, 38% of the time you validated that. You were right to get that Tdap shot. 40% of the time you found that practice was no better or worse than a prior or lesser standard of care, and that's what we called medical reversal. So the provocative conclusion of this paper was if you subject medical practice that is hitherto untested, of which estimates say that's up to half of what we do, if you subjected that to rigorous testing, don't be surprised if maybe 40% of it doesn't work, doesn't do what you thought it did, has harms exceeding benefits. In the supplement of this paper, we actually detail all of the reversals. We detail it in the supplement of our book as well. And if I could urge the trainees, if the trainees walked away with one thing, I would say, print this out. It's like 11 pages long, and read it at your leisure. If you want to know the history of medicine that doesn't make the textbooks, read this history. This is the history of the smartest people, the most compassionate physicians at the best hospitals who believed in all of these things with their heart. They believed in it. They had evidence that lent credibility to these hypotheses, but when they were rigorously tested, they all failed. And I think it's illuminative to know, when you know this history and you see how people have been misled in the past, and then you think about all the things we're debuting and embracing and taking up in our practices, and you really start to ask yourselves, what is different today about what I'm adopting than 1982 when they decided to adopt high-dose chemotherapy and auto transplant based on a phase 2 data and based on a phase 3 from the South African group that was later found to be falsified? What is different about the new what is different about the new practice than this? And you will find that often there's not that much difference, and that perhaps at a minimum we should have more humility about what we're doing. And I think people who think there are parts of medicine that are sacrosanct are mistaken. Reversal affects everything we do, from drugs to procedures to devices to surgeries to screening tests to over-the-counter medications to vitamins and supplements, treatment algorithms. By this I mean, after they used to put stents in, we would check a platelet reactivity assay about a day later when I was a trainee. And if the reactivity assay showed the platelet was not inhibited adequately with Plavix, we would switch him to prasugrel. And then they did a large randomized trial called Arctic, where they tested whether or not you should be testing the platelet reactivity. And that trial was negative, showing that you would increase the drugs to more potent ADP blockers, and you would increase the bleeding, but you wouldn't increase the outcome. You wouldn't make the patients better off. So even this idea that you would measure something in real time and adjust to it sort of a precision strategy, that had failed in a randomized trial, although it was extremely plausible. Diagnostic instruments, systems interventions, quality and performance metrics. Let's not talk too much about the checklist, but everything has failed. Some example has failed in biomedicine. Why is this harmful? I think you will concede to me that there are three clear harms from reversals. One, actually, before I tell you why it's harmful, let me just say one thing about frequency. I think it's reasonable people will say that your estimate may perhaps be inflated or deflated. You may be off by 10, 20%, 30% even. Reversal could be 10%, it could be 70%. And I would say I concede that to you. Maybe I'm not 100% right about my estimate. I'll have a new estimate soon. But what I will suggest to you is that the rate of reversal is far higher than the error rate of frequentist statistics. This is not about statistical issues in trials. Anytime you run a trial, there's going to be a chance that you have a false positive trial. Reversal is not driven by that. It's driven by other things, which I'll show you. And the rate of reversal we're tolerating is far higher than what you'd expect from statistics. And the second thing is, this is a devastating problem, as I hope to convince you. And even though earthquakes are rare in California, we have building code meant to withstand earthquakes. So I think we should take this seriously if it occurs at any of the estimates that we think are plausible. So who does this harm? Well, all of the patients who undergo the practice during the years it fell in favor are clearly harmed. There are patients who are stented. They thought it would decrease MI or improve their longevity. They were misled. It did not do those things. They thought it would improve their exercise tolerance, and perhaps it did, but perhaps no better than a placebo intervention. There are people who undergo the practice during the lag time before it falls out of favor. Medicine is a battleship we don't turn on a dime, especially for practices that are wedded deep within us. And I think that the methamphetamine of being a doctor, the most addictive substance we have, is when you pair doing something that you truly believe is in your patient's best interest with a bit of monetary reimbursement. Together, that is a strong addictive substance. And we see that addiction among providers when they grapple with these studies. And they are smart people, and they think of smart reasons why these studies should be discounted. But for as smart as they are, they don't ask the question, what are the positive studies that justify this practice? And if there were those positive studies, I think these things wouldn't be receiving the attention they do. Finally, loss of trust in the medical system. When we shift mammographic recommendations from 40 to 50, the backlash on that recommendation is fierce. There are people who believe it's about saving money, it's about all of these reasons that actually, frankly, it has nothing to do with. And there are people who come, especially in this day and age, who are quick and ready to dismiss everything we do in biomedicine, and they seize upon these examples as reason or justification to throw everything out. And obviously, none of us in this room would believe that everything we do is foolish. Obviously, much of what we do has tremendous benefit, and some of what we do has unrealized benefit because we can't get it to the patients who need it the most. But at the same time, some of what we do is a free ride or is hanging on the coattails, and we have to tease these two apart. I'm going to skip that for the sake of time. Where does this come from? When I go to talk to people, say, this is my busy slide, and I cringe. But this is my busy slide, so you feel free to cringe. I apologize for this busy slide. But reversal happens for one proximate bottleneck. There are deep reasons why it happens that have to do with human psychology, financial bias, corporate sponsorship of research. Maybe I'll allude to some of those. But there's a proximate reason why it happens. There's an immediate cause, and that is we adopted something in biomedicine based on inadequate or biased studies, and we did so without definitive trials ongoing or forthcoming. We used to do this a lot. In fact, it was the only way we adopted things. We still do it today, even though we've witnessed countless examples of reversal. Why do we adopt things? Well, the pathophysiology is seductive. Sometimes we have pathophysiology, but we bolster it with anecdotal evidence. We have a few case reports. We have that renal artery stenosis, and we have some reports that come out of one interventional group that stented patients and had dramatic responses. Sometimes we use epidemiology evidence. I hope to convince you that many epidemiology studies, retrospective studies, for common exposures in our lives for which people decide if they expose themselves to, those are plagued with residual confounding that we have not really gotten better at circumventing. Historically controlled evidence is notorious. In my field of cancer medicine, many of our clinical decisions are because we treated 40 patients and they did a lot better than they did in 1995. But historically controlled evidence is notorious for inflating benefits and underestimating harms. There are well-done studies that go back to the 80s that prove that. Finally, randomized trials. Simply being a randomized trial does not mean you're a good randomized trial. And many of us have complained that randomized trials have been hijacked in the last decade. They've been hijacked by the sponsors who perform the trials with everything favoring study drugs. And how do they do that? They pick, I should say, inappropriate patients. The patients they're studying are too young, or they don't look like our clinics. The patients are getting comparator dosing that is inadequate dosing of comparators. They have inadequate comparators chosen, the straw man trials. They have prohibitions on concomitant medications, asthma trials where you're not allowed to use certain drugs that are the mainstay of asthma therapy. Some of these trials are single-centered, as we saw with early goal-directed therapy and Manny Rivers, which was contradicted by now 2 multi-center randomized trials. Together, when people talk about pragmatic randomized trials, they mean let's loosen these things up. Let's make this look like all our practice. Let's open this up. That's what it means to be pragmatic. Finally, drug run-in periods, which I hate, and I got into a fight with someone about, which I'll allude to. Our love affair with surrogate endpoints, which doesn't seem to quit. Hemoglobin A1C and LDL, and many others. The co-author of my book put it well. A surrogate endpoint is an endpoint the patient didn't know was important until the doctor told them it was. And we are in love with those endpoints and teaching the patient why it matters and why it's important. And we forget that it's important insofar as it predicts hard outcomes that patients really care about, and some of them do not predict that. Early termination of trials inflates benefits. That's Victor Montori's work. Selective reporting and publication bias. Finally, meta-analysis. People often tell me, well, meta-analysis shows, these trials were all negative, but meta-analysis shows. I like to say meta-analysis is like a juicer. It only tastes as good as what you put in. And people are putting a lot of rotten fruit into this juicer. Because John is here, I want to talk about sham controls. So John and I and Daryl Francis, the PI of Orbita, 3 of us have one thing in common, which is we strongly believe that this is the case, that there are many medical interventions that we perform hoping to improve objective outcomes, like how long people live, or if they have heart attacks, ST elevation heart attacks, which are very they have biomarker criteria and criteria on EKG to show that and a clinical criteria, that total occlusion of the coronary artery. But there are many things we do for patients with the hope of only improving a subjective endpoint, like pain or dyspnea or angina. And when you want to improve a subjective endpoint, let me assure you that the history of medicine has shown that you can be misled very easily, because the power of the human mind to control some of these subjective endpoints is tremendous. And if you have a placebo that's more costly, it works better than a cheaper placebo. And if you have a placebo that's more invasive, it works even better than a less invasive placebo. Many studies have shown. And we see that in the biomedical literature. Meniscectomy for knee osteoarthritis, debridement for knee osteoarthritis, RV pacing for HOCM, which was largely thought to change the gradient and improve outflow in HOCM. Largely, the symptomatic benefit was placebo. Vertebroplasty, the placement of polyacrylamide cement for shattered bone from osteoporosis, lumbar steroid injections, and PCI for stable angina. These are all things where the human capacity to believe you're getting better is so strong that we were only able to know that many of these things did not benefit our patients when we tested them against a sham control in clinical studies. In fact, PCI has an interesting history. In the 1950s, they believed if you tie off the internal mammary artery, you would improve symptoms. And in fact, until they did the sham control trial in 59 by Cobb in the New England Journal, they believed that. But of course, one sham controlled trial, it debunked it. And of course, today it looks ludicrous. Why would tying off an unrelated artery improve angina? So why do I show this? I show this to you to suggest that we still debut many practices that improve subjective endpoints that are highly invasive in the absence of sham-controlled studies, and that is very questionable. John Mandrola has been calling for sham-controlled trials of atrial fibrillation ablation for patients with symptomatic AF, noting that many patients feel better, and then lo and behold, when you put the EKG on them in clinic, they still have AF. These are the kind of studies that need to tease this out. And I think there has been a strong movement in medicine to say some of these trials are unethical because you subject a control group to an invasive procedure with no potential for benefit. But I always point out that when you debunk one of these practices and show it's a placebo effect, what that really means is that you have been subjecting patients, thousands, tens of thousands of patients, to an ineffective procedure for years. So the lesser of 2 evils is to run the sham-controlled trials. The greater of 2 evils is to implement the practice without them. I have limited time, so I will take a survey of the audience. We can talk about one of 2 topics. We can talk about Why does the news flip-flop on studies like coffee, tea, vitamin E? That's choice A. Okay. Choice B is Entresto, the novel heart failure medication for heart failure, and Entresto sacbutyl valsartan. Okay. All in favor of choice A. Why does the news flip-flop on nutritional advice on coffee? Okay, I see some hands. Oh, okay, lots of hands. Now all in favor of Entresto. Okay, I think I'm afraid that the coffee wins. Okay, so the coffee, I guess I see. So in other words, you prove the journalists are right in what they cover in the news media, huh? They're not covering our late-breaking clinical trials. They're covering coffee. You have validated their coverage. Okay. Well, I think it would have been a good choice either way, I hope. But let's because we only have 15 minutes, and I want to say something at the end. So I think many of us in this room know that when we read the news, that if you want to get into the New York Times, I can tell you what you got to do. You got to do a study of blueberries, Dept. Blueberries, dark chocolate, vitamin E, vitamin D, aspirin, metformin, statins. You do a study of those, you have a ticket to the New York Times well column because people love those studies. I think I read a study a couple years ago that said blueberries and raspberries were good for diabetes, but peaches and other fruits with a pit were not. And I thought to myself, what kind of hard-hitting work is this? So many years ago, you would read vitamin E increases all-cause mortality, and you, like me, would throw out every bottle in your cupboard, but the next week, you would be back in Costco buying the biggest bottle of vitamin E you've ever seen when that study was overturned. So why does this happen? Well, about a year ago, somebody explained why it happens. And that was a very clever paper in the journal. No, it's actually 2015 now. Say the same thing over and over again. The Journal of Clinical Epidemiology in 2015, John Ioannidis at Stanford and Chirag Patel from Harvard explained why does it flip-flop so much. Okay, so when we do these studies looking at common nutritional exposures and outcomes, how do we do them? We take a data set that's existing data set, like the NHANES data set, which is a nutritional food frequency questionnaire for many, many years, paired with mortality 20 years later. So we know what somebody ate, and we know if they lived or died. And we go retrospectively and we perform a regression analysis, which means we are using a model, usually a Cox proportionate hazard model, linear regression, log regression, some kind of model to predict mortality. And we put things in our model to say, like, what could predict mortality of these people in this study? And the first thing we put in the model is the thing we care about, vitamin E. But then we adjust for things. We adjust for other things that are in the data set that we think would affect mortality independent of vitamin E, like how old a person was, or what their sex was, or what their race was. Okay, and this data set is out there. It's publicly available. And the software to do this analysis is now ubiquitous. Everyone has it. And I estimate that at any given moment, 1,000 people have the NHANES data set and could be running this analysis. And probably because the question is interesting, people have run it many, many thousands of times, tens of thousands of times. And of those tens of thousands of times, so many get reported and so many get published in the journals. And somebody in Portland may be running this regression analysis. But somebody in Toronto who cares a lot more about socioeconomics may be adding in income. And somebody in Emory University may be adding in smoking because smoking still affects the South very heavily. And they're running a similar regression analysis. And somebody at Harvard is a smarty pants and they may be adding in BMI or hypertension or diabetes or cholesterol or alcohol consumption or education or family history of heart disease, any cancer, race, ethnicity. And in fact, you could add up to 200 different covariates in this data set. But none of us who are doing this research are looking at all of the covariates, and none of us are looking at all of the possible covariates. But in aggregate, we are committing a multiple hypothesis study. We're all studying the hypothesis with multiple preconceived definitions, but we're doing it separately of each other. But because the selection pressures of publication favor only those studies that report significant results, what we read in the published literature may not reflect what the bulk of the iceberg is. It may just be where the tip is. So John and Chirag noticed that you can adjust for different covariates and different people could do different things. So why do we adjust for some and not others? Let's adjust for every covariate and every possible combination. So they picked simple associations, vitamin D and mortality, and they picked simple 13 commonly used adjustment things, and they adjusted for every possible combination of things out of 13, which is, for the geeks here, 2 to the power of 13, or 8,192. If you have 13 variables and you adjust for all possible combinations, you have about 8,000 different regressions you could run. And they plot and they run all those regressions on a Stanford computer, sucking down the electricity of the hospital. And on one axis, they plot the p-value. Actually, it's the negative log 10 p-value, but it's the p-value, more or less. It shows significance in the up direction and less significance in the down direction. On the other axis, they plot the hazard ratio. And they get these clouds of effects. They get these big bursts of clouds. This is a million New York Times stories in one. A million stories from the USA Today and the New York Times and the Wall Street Journal about vitamin E and coffee. And there are these bursts of clouds. And this is every possible study you could be reading. And all of the density, the heat, the hotness of the cloud is usually over 1 and null. It's over the null hypothesis. There is no real association between a couple extra serving of blueberries and mortality. Of course there isn't. Then people would be living so long if they were eating fistfuls of blueberries, and we don't see that. Of course, most of these nutritional things, common associations, don't really drive long-term outcomes, but the burst of it shows the range of possibilities. For some things, you get positive and negative things like vitamin E. I can get you the conclusion you want by picking and choosing the covariates. And what they show is that the published literature are just a few of the dots in this, and it's never the center of the map. Because as I showed you before, if I got the null result, am I really going to write it up to know that no good journal is going to publish it? Is I going to waste my time to write up this article? I'm only going to write it up when I get a hazard ratio of 0.8, because if it's 0.6, it's not credible, but if it's 0.9, it's not good enough. 0.8 hazard ratio, confidence interval, 0.78 to 0.94, that's a JNCI paper right there. That's the one I'm going to write up. And that's what we're doing. We are committing multiplicity. So when we talk about why are observational data bad, there's two reasons. One, they do not minimize confounding. Randomization minimizes, though it does not eliminate, confounding. You balance some of the covariates that may determine if somebody would have gotten a procedure by randomization. But the other thing you do by randomization is you minimize multiplicity. You minimize the number of times you're testing a hypothesis. You minimize that, and that's the other virtue of randomization. Although in recent years, especially with our checkpoint inhibitors, we have removed that because we're doing about 1,000 studies of checkpoint drugs. So we've introduced multiplicity into randomization, some work we've been doing. Okay, so what does this show? This shows why on common topics where lots of people are probing the data set from publicly available data sets with commonly available statistical software, you will inevitably get flip-flopping if the selection pressure to publish is tell me something I haven't heard before or haven't heard lately. I'm going to skip interesting. And in fact, you did validate that actually we did a study a few years ago where we looked at what were the journal articles covered in the news and what were the journal articles that contemporaneously appeared in high circulation newspapers. And the ones in the news were much more likely to be observational studies with low N than the ones in the medical journals over the same time. Because just like you, they chose nutrition over Entresto. 7 minutes. I don't want to go over. All right. What's the solution to this? New costly technologies that are being introduced into healthcare systems are ideal for testing in randomized trials. You don't want to do randomized trials 20 years in when we all have become hooked on it or we're true believers. You want to do it before we have the allegiance bias of these practices. And in fact, once upon a time, we had a regulatory agency that was meant to do that, although in recent years, in the last decade, under tremendous political pressure and a drift of the pendulum towards pro-business interests, I think the regulatory agency has moved the other way. Of all the things we do that we don't really know if they work or not, we need to prioritize them. And there's some frameworks that we've played with, something called a value of information framework. And we need to start running a large non-conflicted trials agenda. Many studies have shown that when the sponsor of the study runs the study, it's more likely to get a result that favors what the sponsor wants, which would be like if I submitted a painting to a painting contest where I was the judge, you can bet I'm going to win my painting contest. Because of course the industry would have, when possible and when legal and within the norms of medical science, favor their product because they stand to make billions of dollars from the results of that trial. Non-conflicted trials, there are still perverse biases. I know that this is another source of debate. I mean, professional biases, we want to shape the field, so we want significance. We all chase significance. But yet there are less biases, and perhaps there are ways we can neutralize some of those biases with better methods. We have a healthcare system where at the federal level, we spend $1 trillion a year on healthcare, and at the federal level, we spend less than $10 billion a year on a clinical trials agenda. And that would be fine if you were paying for things that were all evidence-based, but we're paying for things that are not evidence-based at all. The amount of money we spend on testing things we're uncertain about versus the vast sea of uncertainty is I think, very foolish. And if you were a responsible financial steward, you would realize that one well-done study on a drug like Tamiflu or Entresto or rivaroxaban, it has a potential of saving a healthcare system $3 billion a year. It is in your best interest to conduct such studies. But yet, we don't have that because of a lot of politics and a lot of bad policies. And finally, the design and conduct of clinical trials. I didn't get to talk about Entresto, so it doesn't make sense. But the design and conduct of clinical trials should move towards third-party agencies. It actually should be probably run by methodologists with input from disease-specific specialists, but not the primary design by disease-specific specialists. When I talk a lot about this, I talk a lot about randomization, the need for randomization, and people say, well, you can't do randomized trials for everything. And I will concede there are many things you cannot do randomized trials. Can't do a randomized trial for, I'll tell you very briefly, there are two things you can't do a randomized trial for. One, we do not test putative harms in randomized trials. People always say, there's no randomized trial that cigarette smoking is bad. I was like, well, there's no randomized trial that a gunshot wound to the chest is bad either, but you don't do randomized trials for putative harms or drinking a cup of benzene is bad. You do randomized trials for putative benefits. So if you think smoking cessation is beneficial, you can do a randomized trial of that. And you do a randomized trial for a putative benefit, not a putative harm. The second thing is you do a randomized trial if you believe the effect size of the intervention is modest or mild. You don't do a randomized trial if you believe the effect size is a parachute, which is the common analogy, which is the common joke, which is there's never been a randomized trial of jumping out of an airplane without a parachute, which I hope to cover, but time is short. But this is a nice example of a country that invested in randomized trials. This is the TASTE trial from the Netherlands, and they looked at mechanical aspiration of a thrombus in ST elevation MI. And the blue line shows everybody who came in with a STEMI and received PCI in the Netherlands, and the red line is everyone who underwent randomization. And how did they achieve 60% of patients being randomized when in oncology we struggle to get 3%? This is a pragmatic trial. Because now these patients actually look like the patients who present in the Netherlands because you get 60% of the people in the Netherlands. This is fantastic. There's nothing in American medicine that's this good. And they did it for $50 per participant, not $22,000, which is the cost, in our country. How are they doing it so cheap and doing so well? Because they've invested in a registry-based infrastructure where they can simply insert randomization into normal clinical processes. And I find it interesting that Silicon Valley has so many things that will revolutionize our health, like blood-based screenings for every cancer, even though once you find a positive blood test, I don't know how you're going to pinpoint where the cancer is, but they're working on that. They have 2 companies with billion-dollar evaluations. But no one wants to invest in the thing that would be the single most transformational thing, which is lowering the price and making randomization easy and feasible and practical and something that we could all participate in. Will you indulge me? I will try to. If you have to go, please feel free to walk out. I walked out of many lectures looking at my pager as if there was. Yeah, just go ahead, fake the page. Fake the page. I know no one's really waiting for you. You're just going to get coffee, but that's okay. It's okay. I've done it many times. I've been guilty. Okay, but I'll just tell you the major objection because I think it's worth knowing. When you, as I had come across to you, are a proponent of randomized trials, people will raise this objection. It comes up quite often, which was, did you know, never been a randomized trial of the parachute. Gordon Smith and Jill Pell in 2004 in the BMJ wrote a very provocative, tongue-in-cheek article where they said, we think that everyone would benefit if the most radical protagonists of evidence-based medicine organized and participated in a double-blind, randomized, placebo-controlled crossover trial of the parachute. And so they had us there. Okay. This analogy, I think, has been very misused. There's 2 clear limits. One, the pathophysiology of jumping out of an airplane is different than the pathophysiology of diabetes, heart failure, and cancer in that it has a single common pathway of boom. Okay, we don't have that in diabetes. We don't have that in cancer. We have multifaceted pathways that we are just exploring the tip of. When we do have that, like trauma, if I stepped out of here and God forbid a bus were to hit me and my femur were jutting out of my leg, I would never ask you for a randomized trial of putting my femur back in my leg because it was just there. Okay, so you don't need randomized trials if you really think you know what's going on with the pathophysiology. But if you were resuscitating me for that femur and you're thinking between colloids and and saline, or how much blood you want to give me, or what you want to tank my platelets up to. Those could all be studied in randomized trials. And maybe the way you fix it or at what time you fix it, those could all be studied. I mean, we can ask questions and make knowledge around the central thing of let's put this guy's leg back together. Okay, the second thing is the effect size. So I had a good medical resident, Michael Hayes, and I put him to work on this project, which he took about a year, but we published a nice paper recently. He looked at the effect size of these interventions. So it turns out if you jump out of a plane without a parachute, there are case reports of survival. And if you jump out of a plane with the parachute, you have a 7 in 10 million chance of dying when your chute doesn't open. And that's kept by the National Parachuting Association, of which John is a member, which is why he wears this boot on the foot. But the effect size is an absolute risk reduction of 99.9999993%. That's unheard of. Nothing in biomedicine has that good an effect size. I'll just show you. John Ioannidis looked at everything in the Cochrane database, 80,000 medical practices. He found that the single largest effect size on overall mortality was ECMO for neonates with an absolute risk reduction of 40 to 50% for respiratory distress. That was the single largest thing in all of Cochrane, 220,000 trials, 80,000 papers in this beautiful JAMA paper. Paul Glasziou from Australia and colleagues, they keep a list of everything in biomedicine that we believe works without a randomized trial, like transplant for liver failure. But this list has been passed around, and I've gotten this list before, and people have added to this list, but the list is 75 things. We do about 250,000 things in biomedicine. There are very few parachutes. They're rare in biomedicine. And the last thing we did, this is what Michael Hayes did and published in the Canadian Journal, and I'll end with this. He looked at every one of the 800 references to that parachutes paper. By the way, 800 references in a decade means you are a very influential paper. Very few papers, less than 1%, get 1,000 in their career, lifetime citations. He read every reference to this paper, and that's why God invented residence, and he pulled out all of the specific references that said, we also have a parachute. We're citing this paper about parachutes to say, we also have a parachute, and you can't test my practice in a parachute. But he found that there were 35 of these papers said we also have a parachute. Most of these papers cited that parachute paper just to complain about randomized trials in general. But some people had the courage to name names. And when you named names, we judged you on those names you named. And we found 18 of the 35 had already been tested in a randomized trial, which, to be honest, is not a good sign you're really a parachute, that somebody has already thought you could be tested in a randomized trial. If you were tested in a randomized fashion, 5 of those trials were negative and 6 were positive. And actually, this is actually comparable to actually all trials in aggregate in a paper in Nature. In other words, parachute practices tested in randomized trials are probably no better than average practices. And of the 17 that weren't tested in a randomized trial, some of them, I agree, they're really parachutes, like intubating somebody who's in respiratory failure. When you were studied in a randomized trial and positive, the best absolute risk reduction was 30%, not 50 or 60 or 99. And he looked through all of the endpoints they considered parachute endpoints. And I just want to point out that 5% were about dental outcomes, because the parachute paper has a huge uptake in the field of dentistry, which I found a bit surprising, because I think worst case scenario, lose a couple teeth, and that is not the same as losing your life. So my final thought, the arc of history of biomedicine has taught us that inevitably we will bend towards higher upfront standards of medical evidence. We will have better randomized trials in the future. We'll have less bias. We will not be moving in this N of 1 direction too much. I think there'll still be the need for randomized trials. The rumors of their demise are not gone. And what we can take away, I think, from this kind of work is, when you read about something in your clinic, read the up-to-date article, but then pull the reference. I always like to pull the reference and look at the reference. Sometimes it may not be to your satisfaction. And if it's not to your satisfaction, just know that, this is not a 100% thing, and maybe I should have some humility or shared decision-making. Maybe I'll be wrong in the future. And I think we should walk away with new technologies are not always better. Human body is not like a cell phone. It is much more complicated, much more marvelously complicated, and everything newer is not always better. We should be critical of the literature. And we live in a day and age where there are people like Dr. John and Richard Lehman and other very thoughtful people writing blogs and posting about this. I encourage you all to read them. So I'm sorry I went over. I thank you so much for your time, and thanks for having me.
Couple of questions, and for those of you that need to leave, that have clinical duties and stuff, I'm sure that Dr. Prasad will. Do you have any questions?
Yeah. So this is a great question, which was the eligibility and inclusion criteria of trials has been very strict historically. And that's because historically we have chased idealized efficacy when we should be chasing sort of real world effectiveness. And you can figure out real world effectiveness actually in pragmatic studies. I would say there is a lot of movement in my field, which I know a little bit better in oncology, to do something just like that. The FDA has looked at their drug approvals. They find that patients in pivotal trials for drug approval are 10 years younger than average cancer patients. We've had a lot of real-world data showing that these cancer drugs don't work the same in real-world patients. There's a huge push in FDA to raise the average age, include underrepresented minorities in these clinical trials, there's a push towards pregnant women, towards pediatric populations, because it's a double-edged sword. We long thought you're protected by not being in a randomized trial, but the reality is you're also harmed because information, we never know if it really applies to you. I think there is that movement right now. Oh, thank you.
Providing a little clubber bat, which then
oh,
you can't take it on the plane. And it basically says Vinay Prasad, MD, 2018 Charlie Smith Lecture, University of Louisville, March.
Oh, thank you so
Thank
much.
you.
This is really wonderful. Thank you. That's
you can
great.
Swing a big bat, or you can hang it on your wall.
That's great. Thank you.
I'm sure I knew people would come up with questions.
Oh, good. Yeah. Oh, thank you so much for that.
Yeah, it will be after later. Only million. Yeah. Yeah, yeah. It's on YouTube, so it just send you the YouTube link. I don't think so. Yeah. Yeah. Oh. vibration